About to introduce Dr. Jonathan Alexander. He is a Chancellor's Professor of English and Gender Sexuality Studies at the University of California, Irvine. He is the author of a book, co-author and editor of 22 books, and his research focuses primarily on the uses of storytelling to promote personal growth, political consciousness, and collective action. Jonathan also writes creative nonfiction and is the author of a series of books about growing up gay in the Deep South called the Creep Trilogy, and the Stroke book, The Diary of a Blindspot, which is about his encounter with a medical crisis and his use of writing to deal with it. So please welcome Dr. Jonathan Alexander to the stage.
Thank you all so much. It's a real privilege to be here, and I'm really immensely gratified when I can sort of cross what for me is a disciplinary border. I am a writer, I am a humanist, but I love scientists, and I love medical practitioners, and I love talking with folks who do empirical work, who do work that is really geared towards understanding the wholeness, the physical totality of who we are as people. I've been very fortunate throughout my career to not only have been able to partner with and collaborate with a number of social scientists and medical practitioners, but also increasingly to write in the realm that we call the medical humanities. Some of you might also know it as narrative medicine. And a lot of this stems not only from my own experience with the medical establishment as a patient, but also as someone who has frequently collaborated with scientists, including psychologists and others, to really understand how do we approach what it means to be human in the totality of our humanness, to think about who we are as people that are embodied, that exist in a physical and in a material realm, that also have complex psyches, that also exist within really dense and vibrant sociocultural matrices and political dimensions. And so what I'm going to do today is try to address many of those different axes, matrices, or dimensions, specifically from the vantage point of my positionality as a queer person. And so I want to think with you about what is it like for many queer people, many lesbian, gay, sometimes bisexual, and also transgendered people to interface with the medical establishment, and what are some particular needs and challenges that these folks sometimes encounter. So I'm going to largely work from, like I said, a storytelling, a narrative medicine, or a medical humanities perspective. And so a lot of what I'm going to tell you about comes from my experience of my own medical crisis just a few years ago in 2019, when I had a very minor stroke. What physicians informed me was an eye stroke, which they treated just as a regular stroke. It was a little bit of cholesterol had come unlodged or dislodged from an artery in my neck, and instead of shooting up directly into my brain, kind of took a slight detour through my retinal artery and lodged in a branch artery of my right eye, where it has caused some permanent vision loss in that eye. The doctors were very concerned. I was immediately hospitalized, and doctors were very concerned that this was the beginning of a more, as they put it, catastrophic event. I always love the language. I'm very attuned, as you might imagine, as a professor of English, to the language that people use. So when I was admitted to the hospital, they said, we were watching to make sure that this is not just the harbinger of a more catastrophic event. So it's pretty freaking catastrophic to have already lost some vision. What more could happen? It's like, well, your brain could explode. It's like, okay, I got it. So let's prevent that from happening. So as I began, as a writer, inevitably writing about this event, because I filter most of my lived experiences through words, through language, through my own writing about them, I realized that what I was writing about was not necessarily just the particularity of this event, But it's sort of anomalousness. I didn't have particularly high blood pressure. I had been treated for high blood pressure, but it wasn't outrageously out of control. My diet was stable. I exercised. I was in the gym 3 to 4 times a week. I didn't seem a likely candidate for this kind of medical mishap or biological anomaly. And so I began thinking, well, what is the issue here? What's going on? What are the different ways in which I can understand what has happened to me? And the more I began thinking about it, the more I realized that I could trace over the course of my life a number of different, both physical, but also I'm going to say psychic, I would even say spiritual kinds of issues, damages, torques, a kind of wear and tear, both in psyche and in body, that I trace ultimately to the experience of having grown up in the late 60s and 70s in a very homophobic environment, in which some of my habits for coping were fairly maladaptive. And so while I could recently point to improved diet, regular exercise regimen, and other kinds of maintenance medications to keep my blood pressure under control, those were only relatively recent interventions. I thought I was in the clear. I had worked my way up from the working class. I'd worked my way up into a profession, relative stability in the middle class. I had access to very good health care. I could afford to go to a gym 3 to 4 times a week and hire a trainer to work out with. I could afford to shift my diet to primarily organic kinds of food, to eat as healthily as possible. And yet, all of that couldn't necessarily make up for what was nearly 5 decades of otherwise, at times, maladaptive behaviors. And those maladaptive behaviors, including not eating particularly well, not necessarily attending to my health, even some perhaps, I never thought of myself as an alcohol abuser, but somebody who is certainly alcohol dependent at certain times in my life. All of those things led me to think, well, why? Why did I essentially plant the seeds for so long? What was I doing? Was this just not paying attention? Was this just not being attentive? Was this just not knowing how best to take care of myself? And the answer is yes, in part, because as all of you know, access not only to health care, but access to knowledge about health is often class dependent. It takes money. It takes access to knowledge to know how to take care of yourself. And I did not have those things until relatively later in my life, but also having developed some unhealthy relationships with food and with alcohol, and other ways of mistreating my body and maladapting to the kinds of stressors that I had been facing as a queer person in this culture, led me to realize that I was experiencing an event in my early 50s, a stroke, that I had probably been expecting, I just didn't know to expect it, but I probably should have been expecting for quite some time. And so in my book, Stroke Book, I try to piece together the complex nexus of all of these different ways in which how we grow up, which includes not only class position, but gender, and sexuality, and race, all of these things actually really contribute to not only how we're experiencing ourselves in the moment, but also to how we experience our bodies and how our bodies react or don't, or maladapt, how we consciously maladapt over time. And that sometimes what we do with our bodies is that we are unconsciously planting seeds, maybe even those seeds are planted without our willing knowledge, but the seeds are being planted, and sometimes they can burst forth into ill health, ill mental health, or ill physical health. And so what I try to do is explore exactly how that happened for me. So what I want to do is to kind of think with you over the next, I think Rajam said I had a 4-hour seminar. Okay, no, not the 40 minutes, okay. Think with you over the kinds of kind of theories, but also very much lived experiences that I have not only as a writer been meditating on and reflecting on, but how do I kind of bring my power as a storyteller and also my knowledge as an academic and as a theoretician of the power of stories in our culture to understand this complex nexus of mind, body, psyche, and spirit, and how, in particular, as a queer person, I can understand what are the sorts of things that I need to be able to do, not only to manage my own health and pain, but also perhaps to help educate other people about how you might help queer people who are in your care manage their own health. And so I draw inspiration from two particular figures. One is Audre Lorde, and I hope some of you know Audre Lorde. She's a really important poet, an activist, she's a lesbian feminist, kind of an extraordinary mind, writing in the 70s and in the 80s. And in 1980, she published the Cancer Journals. The Cancer Journals is definitely an influence on my work. Cancer Journals is a powerful, slim but powerful volume in which she talks about, documents her own breast cancer and then mastectomy, and talks very poignantly and powerfully about how her experience of the medical establishment was sort of was sometimes miraculous and then sometimes unfortunately devastating, as she would encounter people who didn't always understand her particular health needs as a woman, as a black woman, and also as a black lesbian. And those are important things to think about, Lorde tells us, that just because she had a kind of cancer that other women might have, or even men for that matter, that how she's going to respond to it and what her care looks like is really going to have a lot to do with her own self-understanding as not just a woman, but as a black woman and as a black lesbian. And that how she understands and how she needs to be treated is definitely going to be impacted by her black lesbianism. And in particular, she notes how sometimes she believes she was denied certain sorts of pain medication because her doctors believed that black people, well, they just don't feel pain in quite the same way that others do. Terrible thought. But something, unfortunately, that several doctors, many medical practitioners believed in the 70s. That blacks in general felt pain differently. And so she didn't need access to the kinds of pain medication that a white woman might get. So thinking about that, thinking about these differences in positionality and how different people experience the medical establishment actually becomes really significant for understanding their care and what kind of care they're sometimes denied and what kind of care they sometimes need. She also, as a feminist, very much believed that the personal is political and the political is itself very personal. And that all of you know, so much of what counts for health and how we understand our health in this culture is never just a purely personal issue. That so much of what we understand about ourselves, our bodies, also has so much to do with how we are positioned politically within this culture. Are we marginalized? Are we allowed sufficient access? Are physicians and other medical practitioners aware of the specific kinds of challenges or issues that different marginalized people actually face? These are simultaneously personal and political issues. I learned a lot also from Paul Preciado. Paul Preciado is a very important Spanish trans theorist who has been really thinking critically about some of the major ways in which trans people, for decades, obviously, have been not only subjects of the medical establishment, but have had to interface with it in order to be able to have access to the kinds of either hormonal regimens or other kinds of treatments that are important for not only their survival, but for their thriving. Preciado not only thinks about trans bodies and trans bodies' encounters with the medical establishment, but has, and I love this word, has created what he calls the pharmacopornographic era. This is the era that Preciado says we live in, the pharmacopornographic era. And basically, this is a fairly fancy word, and this is why I love being an academic. We get to say these sorts of fancy things. Pharmaco, you obviously know what that means. Pornographic, you know what that means as well. He says our culture, Western culture in particular, is sort of driven by sort of medical interventions, driven by the administration of different kinds of medicines, different kinds of substances, different kinds of chemicals, which are designed, we hope, to ameliorate pain or to enhance functionality, et cetera. Although they often themselves have toxic side effects. But our culture is just as much driven by the pornographic. And what Preciado means by the pornographic is to think very broadly about how all of the ways, even in a very puritanical culture like our own in America, think of all of the ways in which we would just say sex sells, or we're surrounded by different kinds of imagery, different kinds of sounds, our music, our television, our films, the way we dress, all designed to excite. And if not specifically to excite pornographically, at least to excite, to tease, to attract attention. And so what Preciado is doing is saying that if we're to understand ourselves right now, not just trans people, but all of us, we have to understand how we exist in a very complicated matrix that on one hand is full of incredible biomedical ingenuity and creativity and innovation, but also profound sociocultural pressure to conform in certain ways, to make your body look in particular ways. So for instance, even if you are not trans-identified and you're undergoing any kind of transition, think about your own daily regimens, your own regimens of self-care. Do you take psychotropic medications? Do you regularly go to the gym? Going to the gym regularly, like I did before my stroke, 4 or 5 times a week, Preciado would say that's part of a pharmacopornographic constellation, a way of thinking about my body. I'm lifting weights. I am moving chemicals from one part of my body to the other. I am increasing the endorphins and the serotonin in my system. But I'm also trying to sculpt my body to look a particular way, to adapt my body to a cultural norm that will make it more likely that I get attention. Because we know obese people in our culture do not get the same attention that more normatively, or I say normatively, not like that's necessarily a good thing, but that non-obese people do. We understand that. This is an actual fact of our culture, that people whose body shapes look really different from our perceived norm, which may itself not necessarily be all that healthy. It takes a lot of energy, a lot of effort. You can actually really hurt yourself trying to get to that particular norm. All of these things form who we are, from the drugs we take to the kinds of chemicals that we provoke our bodies to produce while we exercise or while we eat or while we consume beverages, to all of the different kinds of pressures that we face in order to make ourselves look attractive to each other. All part of the pharmacopornographic dimension of what it means to be here right now. And what I love about both Lord and Preciado is that they're trying to take some of their experiences from being a black lesbian to being a contemporary trans man and saying all of us can benefit wherever we are, whatever our identification or community is, all of us can benefit from thinking about the experiences of those of us at the margins. We can all think more critically about what it means to be healthy right now. Now, if I turn right now to speak specifically about LGBT folk and their specific needs and challenges when interfacing with the medical establishment, I want us all to recognize that it's one thing to talk about LGBT community, which doesn't exist, and something more to talk about a conglomeration of different communities and identities. And that's really important. LGBT contains within it not just 4 separate kinds of identities, but even many, many more identities over and beyond, represented just by those 4 letters. And so it's very difficult for me to talk about a community, but instead I think of it as a conglomeration of different needs, of different kind of cultural and dispositional attitudes and understandings of the world. And so there's no way in which I can give you information about, hey, here are the 4 things you need to be able to do that will satisfy all of your LGBT patients and clients. I wish I could do that. That's not possible. That's actually not even, I think, desirable, because it would so run roughshod over the complexity of what it means to have an identity in our culture today. It would be like saying, oh, well, all of you straight people are exactly the same, as I know you are. So we won't go there. I will say that you can find some, the word that came to mind was relatively inoffensive information at the Centers for Disease Control, which actually has tried under the current administration to provide some basic guidelines for dealing with gay and bisexual men, men who have sex with men, with lesbians, with women who have sex with women, and with various members of the trans community. This is also not even to think about members of the intersexual community or the growing number of people who identify as asexual. So there are not sufficient resources either for intersexual or asexual people. But the CDC does have some relatively easy to find, and I think fairly inoffensive and usable bits of information that you can find for specific identity categories. Always important to keep in mind, notice what I said. I said gay, bisexual men, and men who have sex with men. Because not all people who have sex with members of the same gender identify as either gay or bisexual or lesbian. That's very important to keep in mind. You can also, unfortunately, I'm not going to be able to pull this up online, but I can definitely send this around to folks who are interested. A colleague just sent this to me this morning, and it's a rather incredible article that was just published on Medium, maybe one of the best documented and most comprehensive articles about recent political issues and legislation aimed at limiting trans folk and their ability to gain access to the medical establishment, their ability to adopt children, and also limiting the access of young people, so minors, to appropriate therapies to address their needs as trans folk. This was published in Medium, Trans Emergent, Trans Erased. And I can easily send that to all of you if you're interested. Just don't hesitate to ask me. I want to provide you both the information from the CDC and this just recently published article, because there are so many issues that we could spend time kind of getting into, and I'm happy to try to address as many questions as we have time for. But I did want you to at least have a couple of resources, some from the federal government and then some also from the private journalistic sector, which can give you more information about what are the kinds of issues facing members of the LGBT community. Trans folk in particular right now are facing extraordinary difficulties. There may not be another group in our culture right now that is facing so many actively negative legislative battles where entire state governments are moving in order to restrict trans people and their rights. And so it's very important to kind of keep in mind that obviously, even if you were to live in a state like California, for instance, in which we are not facing these kinds of battles, just hearing about this kind of news, just hearing about it, creates a climate of stress and anxiety that absolutely will have deleterious effects on people's health. I could spend a lot of time, and I am going to talk a little more personally in a moment, but I could spend a lot of time talking about how I am delighted that my husband and I, we've been together now over 25 years. Oh, that's just not an accomplishment. That's just a lack of imagination. Sorry, honey. I know we were both grateful that we were able to legally get married in 2008. And yet, I can't tell you how many times I went to different city and state voting booths in which I was confronted with having to vote on an ordinance about whether or not we would be allowed to be married, whether or not we would even be allowed to have access to civil rights to claim discrimination. We lived in Ohio for a long time. I grew up in Louisiana. My husband's from Colorado, where we also lived for a while. These are all places in which I have been in too many voting booths to count, in which I've been having to vote, yay or nay, on whether I would have access to comparable kinds of rights, or whether I would be able to claim discrimination if my landlord decided to evict me just because I'm queer. That can't not have long-term cumulative effects on one's mental and physical health. And so if I talk about the larger sociocultural and political matrix in which we live as absolutely necessary for thinking about our physical, physiological, and material and embodied health, that's the kind of thing I'm talking about. So what I want to do is to kind of give you 4 pointers, or at least 4 things that I hope we can talk about during the Q&A, and then I'm going to unpack a little bit some of my own experiences as a queer person in this culture to support how it is that I've come to these 4 items that I think all of us, as people who work with other people, as people in service industries, tending to the needs of other people, because I think of myself like you. I've been a teacher for over 30 years. I feel like I'm in a service industry. I am ministering to the needs of people, and I know you are too. I want to think about these 4 things that I think are important to keep in mind for LGBT people in general. And this comes from my own phenomenological research, my own investigations and storytelling, and my consultation with a variety of different kinds of resources, including the work of Audre Lorde and Paul Preciado. The first I call Me By Your Name, which is very important to use the terms that people give you. There are so many different ways in which we identify, in which we understand ourselves, and it can seem like such a small thing, but it's really important that if somebody announces, I am so-and-so, and these are the words that I use to describe myself, just repeating those words alone, or honoring the pronouns that people use for themselves. That alone can create not only rapport, but a sense of respect, that you actually see and respect our individual right to self-determination. It can be challenging. Like many of you, I'm old enough to have grown up when we thought there were only 2 genders. I have made the mistake several times myself of not referring to a non-binary identified person with the pronoun they. Fortunately, people are calm, people are generally very patient, they offer correction, and I take it, and I apologize. But just making that effort to call people with the terms that they use themselves it seems like such a small step, but it's a radical way in which we recognize each other and in which we say, I see you, I want to help you, I want to respect the totality of who you are and how you understand yourself in the world. The next thing I call is what's sex got to do with it? And for LGBT queer people, gender and sexuality are a huge way in which we understand and think about ourselves, because they are often the things that other people have called attention to. You don't look like a normal person. You don't want what a normal person wants. So to think about one's gender, to think about one's sexuality intentionally is really important. And unfortunately, Many of the medical practitioners that I have interfaced with are not interested in having these conversations. I am 55. I have had one primary care physician directly address my sexual health. One of the 20 or so primary care physicians that I've interacted with in 55 years of living. And that includes nearly 16 years of living in California. And this individual wasn't in California. Only one person has inquired about my sexual health. That's stunning to me. Where it is appropriate, I ask people to inquire kindly about people's sexual health needs and concerns. The fact that we do not do this as nearly as much as we should speaks volumes to our ongoing Puritanism and unwillingness to talk about these most intimate areas of existence that are so profoundly important for people. And so profoundly important, especially for those of us whose genders and sexualities have actively been stigmatized by this culture. It also becomes important. One of my dear friends was diagnosed about a decade ago with multiple sclerosis. And she was given several different kinds of medication, and she was told, well, you know, these medications have side effects, but those are things you can live with. She said, well, wait a minute, what are the side effects? Well, this kind of medication generally kind of greatly reduces libido, so you might encounter some sexual dysfunction, but it's not really that. Most people just adapt. And she said, I'm a lesbian. I'm in the prime of my life. If you take away my sexual functioning, which I have striven for decades to feel comfortable with, that's not a minor inconvenience. That's not a small thing. And so while she was willing to take the medication, she did not want her sexuality to be understood as a small thing to sacrifice. I hope that makes sense. It's all in the family until it's not. Keep in mind that many LGBTQ people have had very toxic family relationships that are actively harmful to their physical and to their mental health. It's really important. It's easy to forget this. I can't tell you how many times I've been with friends, I myself have been with other family members who are queer, who have encountered this kind of just thoughtlessness, often from physicians who will not necessarily recognize that immediate family members are sometimes the last people that LGBT people want to go to or to confide in, or whom they will use as resources or understand of even as next of kin. And so when people push back about this, when people say, oh, well, you really want a family member, and I have seen these conversations, you really want a family member with you as opposed to this person. Sometimes this person, this friend, this member of a chosen family, of a logical as opposed to a biological family, this person is far more valuable, far more useful, far more able to actually tend to the needs, both bodily, psychically, and spiritually, of the individual being treated. And so it's important that we keep that in mind, harping on whose family member should be contacted. Sometimes it won't be a blood relation that is the significant other. That's significant. Finally, I want to talk a little bit about what I call gone but never forgotten, and to recognize that all of the LGBT people that we work with have definitely been traumatized by past experiences with the medical establishment. And this is an unfortunate reality. And I stand here today as somebody who's not only married to a health practitioner, and I hope respectfully addressing a group of health practitioners, that the LGBT people that you treat, I guarantee you, have been traumatized by the medical establishment in some capacity. I want to talk a little bit about that because it actually helps to kind of see how this works. So I'm just going to do a quick run through. In 1985, I sat in a Catholic boys' school. I see people are already laughing at my pain. And we were given sex education. Do you know what that sex education consisted of? Oh, I wish. The only sex education I got, was a slideshow of aborted fetuses. And I was told this is what would happen if you have sex. I can't even really also tell you, although I will, about the health sciences teacher who would regale us with stories. He also worked part-time in an emergency room. He was studying himself to be a doctor. And he would regale us with stories about all those crazy faggots would come in and you'll never guess what they'd stuck up their asses. This is in the 1980s. It's not that long ago. But you can imagine, here I am sitting down, proto-queer kid. I'm definitely being told, without a doubt, that being queer is pathological, but also for all of the young men that I was studying with in high school, that sexuality itself, the view that we were getting of sexuality itself, was one far more of harm than of anything else. That shapes a young mind. In 1992, I was on the verge of getting married to a young woman that I was in love with. It was a young bisexual man. I had had some sexual experiences in college with members of the same sex. But my soon-to-be wife and I, in love, very much wanted to get married and leave Louisiana. So I went to get an AIDS test because I was concerned. I didn't want to have sexual relationship with her if I had been exposed to the HIV virus. And I had had some same-sex sexual encounters. Keep in mind, at this time, late 80s, early 90s, we did not have the regimen of retrovirals that we have now. We did not have all of the drug cocktails that we have now. HIV infection was still a death sentence. I grew up as a young man in college watching Rock Hudson die on national television. I went in to the Student Health Center at Louisiana State University and asked for the HIV test. They wanted to know why. I said, because I want it. Nurse took me back, sat me down. Nurse in the room said, "What is he here for?" "Oh, he's here for that HIV test." What a shame. That's just a shame. He looks like a nice boy. I walked out so ashamed. 2 weeks later, when I had to call for the results, I said, "Hi, I'm Jonathan Alexander. I'm calling for my test results." And the nurse on the line said, "Okay, hold on. Let me look through your file." I hear papers ruffling. And then she says, "I'm going to have to let you talk to a doctor," and puts me on hold. I thought I had died in that moment. I didn't breathe. For the minute it took the doctor to get on the line, I could not breathe. The doctor came on the line and said, "Okay, yeah, you're fine. Your test was negative." Why could that nurse not have said that legally at that time, only a doctor could offer the test results of an HIV test? Would it have taken just one moment of kindness or thoughtfulness to say, only a physician can render these test results. Just hold on. Small things, they leave an impact. In 1996, I'm sitting in yet another doctor's office. I am, at this point, dating the man who will soon become my life partner. And I have a pain in my jaw. I'm like, where is this pain coming from? And the doctor holds up a stethoscope and says, oh, you have TMJ. I can hear it. I can hear it clearly. And I said, oh my God, I feel young to have TMJ. He said, well, you probably are just irritating your gum, your jaw. What are you doing? Stop chewing gum. And I'm like, oh, I don't chew gum. And then it hit me. Oh, I know what I'm doing. There was no way really for me to talk about that with the physician. How do I talk about it? On the verge of coming out, the verge of entering into a long-term relationship with another man. How do I talk about these things? Everything that I had been told before about, everything that I had encountered before in terms of health or medicine had not prepared me at all to actually talk about the particular health needs that I might have. Then we get to 2004. My long-term partner and I are living in Ohio, and he calls me up from work because he has a pain in his lower gut. Turns out he needs an emergency appendectomy. So we take him to the hospital. And fortunately, people are kind enough. I'm waiting in the waiting room while he is in surgery. We had been told, hour and a half, won't take that long. It's 2 hours, 2.5 hours. It's going on 3 hours. And I'm not hearing anything. No one is coming out to say anything. So I go up to the nurse on duty and I say, my partner's been in surgery for quite some time. They said it wouldn't take that long. It was just a routine appendectomy, but it's going on 3 hours. And I'd love to know what's happening. And she looks at me in the face and says, sorry, and who are you? I said, sorry, I'm his partner. I'm sorry, are you family? And it's at that point I lean in and I say, I'm the only one here asking. And you can tell me what it is I need to know. Then we get to 2008. We've moved to California. I'm sitting with my new primary care physician. Very intelligent woman, supposed to be an excellent clinician. She sees both me and my partner separately, but she knows that we are together. And she says, well, we're just going to go ahead and run a full STD scan on you. Now, by this point, I'm well aware of what my sexual activities are and of what my husband's sexual activities are. I am aware, and I say, I don't think that's really necessary, but, if you want to. And she says, oh, yeah, I know how all you gay guys are. And then we get to 2019, when I wake up partially blind in my right eye, go to the hospital, I'm checked into the hospital. Eye stroke might be the harbinger of a more catastrophic event. And I'm under observation, being given different medicines. Nurse comes into the room and says, okay, so you're Jonathan, and who are you? And Mac says, I'm Mac. I'm his husband. And she goes to write on the whiteboard, okay, partner, Mac. And Mac says, no, I'm the husband. And she looks at us. And there's this pause. And says, okay, I'll use that word. All of these are just handfuls of incidents. I know they might individually seem small, although for God's sake, they're not. A man in his 20s hanging on the phone, thinking that he's about to receive a death sentence because someone wasn't thoughtful enough to say, legally, only a physician can render this lab result. Or even me in my early 50s, lying in a hospital bed, having suffered some awful catastrophe, something I wasn't prepared for, and someone is going to quibble about the name that I give, the name that my husband gives himself to describe our relationship. Someone's going to hesitate. That's not acceptable behavior. It's not behavior that contributes to health. It's not behavior that contributes to the well-being of other human people. Using the words that are important for people is acceptable. It's appropriate. It's respectful. Inquiring about people's sexual health and wanting to know what's important to them and how we can best treat them with an eye towards helping their sexual health, helping them sexually heal or attain the ability, the maximal ability to engage in healthy sexual behavior. That's important for all of us. Thinking about the people that are important to our clients, to our patients, to our students, to our friends, to the people that we work with, thinking about who first and foremost is their family, even if not blood relations. That's important. And then finally, also thinking about how all of the different histories that we have encountered are always there. All of the traumas we've experienced never go away. They are always there, even if we're not consciously aware of them. And they shape how we understand who we are and how we interact with the medical establishment, how your patients will interact with you. Guaranteed, if they're old enough, they've had some trauma, they've had some misunderstanding, they've had some lack of care. I hope my charge to you is to just be open, to think critically, think compassionately about the people that you serve. I try to do so every day myself. Thank you so much. We'll have some questions now. How do you want to do it?
Well, we'll just go. Any questions online, in the room? Can also take comments, thoughts, feelings. You've left them speechless.
It's a lot of interesting. It's not a powerful material. Your reactions, it would help me. Like I said, I don't normally get an opportunity to speak to this kind of audience, so your input would be very valuable for me.
I mean, people take time. Well, first of all, thank you for invoking the brilliance of Audre Lorde. Don't often get to see that in this space. And so, because I've been part of the physical therapy and rehab profession for a while, I know I don't look it. Little ageism for y'all there. But talking about sexual health, if you're not a cis heteronormative man where we see ED pills everywhere, how I don't want you to speak for the lived experiences of all these, this spectrum of people, but is there a thought as to creating a space to address this without causing more harm?
That's a great question. Thank you. How do we do that? And, my sense would be that we don't sometimes want to, obviously we don't want to cause harm, right? We don't want to create discomfort or to do something harmful. And then more often than not, we're silent because of that. And I think that in my experience, most queer people or LGBT people would rather have you ask a question as opposed to remaining silent, saying, how do you feel about, or is there something that you could tell me that is important to you? But all of us can have these questions. You raise the specter of the cis white heterosexual male, right? Cis white heterosexual males have sexual and gender issues. They have them. And I think that to the extent that we're not actively asking people, it's like, tell me about your sexual health. That becomes a problem. We're scared. I think sometimes we put a burden on the marginalized to talk about their issues. And that's unfair, because it's only adding stress. Absolutely. I have learned at this point, at 55, I will advocate for myself. Absolutely. But goddamn, it's taken me a long time, and it's still stressful. So while I encourage all of my queer and other marginalized friends to advocate for themselves, I also actively want to try to make an environment in which people are inquiring about these things. I'll tell you a very quick story. I've worked for a long time in college administration, and in my previous position during the pandemic, we had a staff organization of about 100 different people, incredibly diverse people from many different walks of life, many different racial and ethnic backgrounds, a few different genders and sexual orientations. And when the news came down that we all were going to we had to receive the COVID vaccination, our uppermost administrators were sort of, oh, this is great. We're going to make it so that everybody can get the vaccine, and this is wonderful. And look at the ingenuity of our medicine. This is absolutely wonderful. And I had a couple of staff colleagues who are African American who were like, I'm uncomfortable. And they turned to me, and I said, I have to admit, I share some of your discomfort. And I had to sit down with our uppermost administration and say, look, your joyous proclamation that the COVID vaccination is now going to be available is met with some concern, not because these are anti-vaxxers, but because these are people who have, like me, had negative experience of the medical establishment. They come from positionalities in which there isn't necessarily a good track record. And so you're asking us to get on board with the joy train. Maybe you need to practice a little more sensitivity around the fact that not everybody has the entitlement of complete trust in the medical establishment. And so that was just a moment in which I felt like I could ally with other people to talk about the fact that not all of us experience medicine and care in the same exact way. Just acknowledging that is important. So.
I just wanted to say a comment. Thank you so much for your presentation. I really appreciate your openness, and it was deeply moving and insightful. So thank you.
Oh, thank you very much. Thank you.
Hello, thank you. fellow Alphabet Mafia friend over here. And I just want to say I've been privileged enough that I've chosen to only live in states that are safe for me. And hearing some of your history and timeframes, you haven't. And I thought it might be helpful if you had tips for some of the practitioners who work in some of the states that aren't safe places for us.
Oh, absolutely. Let me be clear, I just got back from a conference in Chicago, and I told Mac when I got home, I said, I always feel good. I always feel good coming back to California. I do. I love this California Republic. It's not utopia. And there are issues here. And some of the issues, some of the incidents that I talked about were from here in California, right? Or when I had my stroke, that was actually in Colorado, another fairly liberal-ish, purplish kind of era. I will also say I've had some extraordinarily good medical treatment in places that aren't blue. I think that instead of thinking about who lives where and in what kind of state you're in, I think just keeping it at the personal interaction, you, one-on-one, wherever you are, trying to do the best that you can to meet the needs of the people that you serve is the very best that you can do. And then actively share that with the people around you, whether you're here or there, whether you're in California or in your Alabama. Wherever you are, doing that is probably the most important thing you can do. That will help. I mean, if you are in a state where there are anti-trans legislative bills being passed, I urge you to educate yourself. I urge all of us to educate ourselves about this, even if we live here in California. Wherever we are, we need to know about what's happening to trans folk. More and more young people are identifying as trans or as non-binary, because that's just how our species is. This is not a wave of, the media is corrupting youth. No, it's just, this is how we are. And if more people recognize that there are options, they're going to take the options that are natural and healthy for them. Because humanity is not a singular or dyadic thing. We're a plural species. So to the extent that we're all educating ourselves about the needs of different people wherever we are, and then share with each other the information that you discover that you have. Activate your networks. This is an incredible summit. I sat at lunch with people from, I think we were like 3 different continents, right? This is extraordinary way in which you can have the opportunity now to share with people whose experiences have a global reach. So meet your people where they are and share with your colleagues.
Okay. Yeah. We'll take Abby's question or
and
thought,
then we gotta go.
and then we gotta go.
Thank you so much for your talk. I'm Abby Gordon. I'm a sports physical therapist in a pediatric pain clinic. So I get LGBTQ patients with pain as my patients. And your 4th bullet, gone but never forgotten, and the impact you have looking back is where I'm looking, because I'm at the beginning of this journey for those patients, and I'm wondering if you can look back in your journey and tell us, if you were coming out to your medical provider, or you were starting to learn about your identity and your medical provider is the supportive person in that situation, how can we help avoid this for those patients?
That's a great question, and thank you so much for the work that you do with these young people. I'm amazed at our young people. They themselves are teaching us so much about honesty and courage and being open. You probably have heard things that it would have been impossible for me to even think about articulating. I couldn't even have imagined describing myself 20, 30, 40 years ago in ways that you're probably hearing on a regular basis. One of the things that would probably be important, and I talk about this with my students all the time, and the LGBT young folk that I mentor, is to encourage them to, I don't know how else to say it, not take advantage of the privilege that they currently have. We live in a very precarious world. And we still live in a moment where, yes, more than ever, we can take joy and we can be exuberant about our identities and our communities. And yet they have to be actively tended. They have to be cultivated. And that's what's really important. So even now, providing young people with information about resources, or even just inquiring, hey, how is your friendship group? Are people supportive of you? And if not, here's a local group. Here's a local youth group that might be important. That's really key in so many ways. Because I also don't want to assume that just because we live in a somewhat more tolerant time, that people are always going to be encountering tolerant people, because we know they don't. So this is where, even though we're dealing with younger people, recognizing that the gains that have been gotten are still precarious in so many ways, and that people still need support. They need questions. Even just the question, how are you doing with this? That means a lot. Thank you all so much. I really appreciate your attention.